patients.
For nice, I hope nice introduction. I couldn't understand the word, but I believe it was nice introduction. Anyway, thank you for invitation again. And what I want to share with you are a little bit more distal perspectives in treatment of our schizophrenia patients, and I want to focus on the functional outcome, what it means for our patients and how they are actually doing, and we can do anything about it in regard of our psychopharmacological treatment. But before we get to our patients, let me get a little bit broader picture perspective. We live in the European Union, and Europe loves to measure all aspects of our lives. These are the data from a very recent survey among European countries, including so-called enlargement countries, including Turkey. You can see the red line. And the survey was concerning quality of life, life satisfaction, life happiness, or optimism about the future. This is the response to one simple question on a scale from 1 to 10, how happy or how satisfied with your life you are right now, from 1 to 10. See, there is a European average mean. This is Turkey, pretty low in terms of life satisfaction, but don't get desperate because we Czechs are right below you. We are even more hopeless than the rest of Europe. Not surprisingly, people who are quite unhappy live in countries of Balkan, Bulgaria, Hungary, Kosovo, Greece, and on the top level, people who are most happy are Scandinavian people from Denmark, Iceland, Finland, and Sweden. These are the actual numbers, and I chose the Turkey as the host country to see how they are doing in terms of life satisfaction. This is always minimum, and the maximum, the best rating. This is the mean. You see that the Turkish people are a little bit less satisfied with their life, as we saw in the previous slide. They are less happy, but they are more optimistic about their future than the rest of Europe. So it means perhaps the Turkish economy is doing so well. I don't want to make any shortcut between life happiness or life satisfaction, economic life or material aspects. One of the factors which contributes to our life satisfaction is definitely health. And these are the same survey from the European Foundation for the Improvement of Living and Working Conditions. You see that the satisfaction with health in terms of Turkey is about the average of European Union, but on the scale of mental well-being, Turkey is rating lower than the average is on the lower end. The fact that our medical condition, our overall health contributes to our life satisfaction and quality of life is supported by another very nice study which I really like. This is a survey from Finland. It was published a couple of years ago from a general population, and they were actually measuring quality of life with different scales, and there was among adult population older than 30 years, and they asked them, how is your health? Do you have any medical condition? And they also used the clinical interview for diagnosing mental illness. And they measured the impact of having any disorder on your quality of life using two different measures. One is the health-related quality of life loss by condition, or annual quality adjusted life years loss per 1,000 people. Different measures. We don't have to stop here. I want to point out is that the mental disorders, like depressive disorders, psychotic disorders, and anxiety disorders, ranked among the most severe illnesses of all in terms of impact on the overall well-being. The number one disorder was Parkinson's disease, but mental disorders are right below Parkinson's disease, and they have more negative impact than, for example, stroke, heart diseases, or diabetes, or cancer, disability from accident, or loss of hearing. So this just gives us some idea how important is mental health to our overall functioning and subjective well-being. And it's not surprising that in psychiatry we have effectiveness measures like quality of life, cognitive functions, but also some real-life measures, like, for example, subjective satisfaction with medication, or ability to function in society, and the WHO recognized the quality of life as an official measure for outcome in psychiatry. The relationship is a little bit more complicated. I don't want to make any implication that the quality of life equals overall functioning. There is just a partial overlap of these two domains. But definitely both of them are affected by illness itself, either directly or indirectly through cognition. And from the other side, we are trying to improve those two domains with our treatment intervention, drug treatment, psychosocial interventions, case management, and so on. And sometimes we can actually worsen the quality of life with, for example, if the side effects prevail and they can create additional burden to our patients. This is a survey, a recent phone survey among Czech psychiatrists who were asked a variety of questions, and one of them was rate importance of the therapeutic goals in treatment of schizophrenia patients. And this is just support of my statement that the improvement of functioning could be an important treatment goal, which is quite recognized also by psychiatrists, right behind reduction of psychotic symptoms, reduction of aggressive behavior, relapse prevention. Surprisingly to me, most of the psychiatrists, almost half of them, they claimed they assess functionality of their patients at every visit, which I privately doubt, but we don't have any measure how to actually see if this is correct or not correct. But when they ask them, how do you measure the functional capacity of your patients, majority said that it was just based on the clinical interview. Just about 1/3 use some specific scales. The most frequently used is PSP scale. This is the personal and social performance scale, which is quite widely used in some pharmacological studies. This scale is based on 4 domains, the rating from 0, 1 to 100, when the 100 is the top rating, and based on 4 domains like the social functioning, interpersonal relationships, self-care, and aggressive and disturbance behavior. We did a cross-sectional, very simple study when we are trying to assess the functional capacity of our schizophrenia patients in 2 countries which share similar background, similar history, Czech Republic and Slovakia. We had 2 goals in mind: to assess social and functional impairment in the sample of our patients, and to also look if there is any relationship between the functional impairment and the current antipsychotic treatment, plus some selected demographic parameters. This was a naturalistic, non-interventional, and, as I said, cross-sectional study. We included stable outpatients with diagnosis of schizophrenia. We asked 100 outpatient offices across 2 countries to collaborate. They were about to include approximately first 10 patients with diagnosis who were attending their offices within a time limit. The instruments used were CGI for symptom severity, PSP, personal and social performance scale, for the functioning subjective well-being under neuroptics, plus all the data on the drugs, concomitant medication, and demographic data as well. These are the results. As you can see, this is the study sample. We were just short of the planned 1,000 sample. We had 925 patients. Majority were males. This is the stratification according to age. And these are the actual data. The majority of patients fell into the mid-range of rating of the PSP scale. Just a reminder, PSP scale, we can artificially divide the final scores into 3 ranges, when the top rating above 70 would indicate little or no functional impairment at all. 30 to 70 is the moderate severity of impairment with different degree of impairment, and 1 to 30 would be patients who have very poor functioning, very severely impaired. As you can see, 70% of our patients from the total sample had some degree of impairment. We looked also into the data on the subjective well-being of neuroleptic, the satisfaction with medication, and there was a difference. The Czech females, they did best, and due to the fact the overall Czech sample were superior to the satisfaction with medication in Slovakia. We don't have any clear explanation. There are not so much different prescription patterns. The data which indicate that the females are doing better would support the notion that there is a better prognosis for schizophrenia among female patients, but it was not true for the total sample. We found, not surprisingly, a positive correlation between the functioning and the subjective well-being under neuroleptics. That's not surprising. The same applies for a negative correlation between severity of illness and the PSP score, again a measure of overall functioning. And looking into the data on demographic, first this is the confirmation that higher education is a predictor of better functioning. Higher education patients achieved, the better they scored on the PSP scale. Both applies for males and females. We also try to compare 2 groups. One group would be the highest level of functioning, PSP 70 to 100, with the rest of the patients, if there will be any differences in the demographics, and we found non-significant trend for being in a stable relationship, either married or with a partner, for patients who have better functioning. The significant difference, not surprisingly, again, because that's one of the domains of PSP scale, was found in the work status. Any useful activity, and by useful activity we mean paid or unpaid job, or part-time job, volunteering job, or being a student, was greater likelihood to do better in terms of the overall functioning. As for the medication, this could, on the first sight, look quite obvious that patients on monotherapy were more likely to be, patients who were in the range of the highest functioning were on the monotherapy, but on the other hand, the patients with the poor functioning had more combination of medication, but the causal link could be the other way around, because patients who are not doing well, they actually require more medication, they require different combination of drugs. Since this is a cross-sectional study, so the design is a shortcoming, we cannot actually explore this any further and to claim that monotherapy would be better for our patients. We didn't find any difference in terms of individual drugs, so we grouped those drugs into groups, so like atypical orals, typical oral antipsychotics, atypical depot and typical depot antipsychotics. And again, there was a majority of patients fell into the mid-range score of the PSP scale, no significant difference was found in this measure, and the same goes for the subjective well-being under neuroleptics. The subjective satisfaction was about the same for all 4 groups of medication. I'm coming back to the survey among psychiatrists. Actually, it was maybe not so surprising that the psychiatrists, they believe that the functional outcome is an important measure. They believe also that there are some effective therapeutic interventions, psychosocial interventions, pharmacotherapy or psychotherapy. And they believe that change of antipsychotics, change of dosing of current antipsychotics or combination could lead to some improvement. Unfortunately, we did not find any evidence for this in our study, but this is maybe for the methodological reasons. But the good news is that the psychiatrists actually expect more from the medications we are using. And it's not about us, it's not about some artificial concept of functionality or quality of life. There is a survey a couple of years ago published by John McIntyre. This was a global survey among patients with schizophrenia and bipolar disorders, and one of the questions they asked them, what aspects of care would you like to improve? And just behind less risk of weight gain or better treatment of depression, it's quite encouraging for me that the patients themselves, they want to improve their functioning, quality of life, and they want better treatment for their social withdrawal. So, in conclusion, let me summarize what I was trying to tell you. First, I believe that the mental illness or mental health has severe impact on the overall functioning and well-being, and there are some valid outcome measures which could serve as real-life proxies. In our sample of schizophrenia outpatients from 2 countries, mid-Central European countries, almost 1,000 patients, most of the patients had moderately severe impairment, and the highest level of functioning, highest satisfaction with medication was found among the Czech females. The functional capacity correlated positively with subjective satisfaction medication and negatively with severity of symptoms, and the degree of education was a predictor of better functioning. We didn't find any difference between the antipsychotics, but there were people with the highest level of functioning were more likely to be on the monotherapy. And again, I should warn you that this could be the other way around. And finally, I believe that the functional capacity can be easily assessed in everyday clinical practice, and both doctors and their patients, they perceive the functioning as an important therapeutic goal. And we feel, based on our data, what we saw, that this is actually one of the unmet needs of our patients. And I want to end here with the picture of our future home. This will be National Institute of Mental Health. It's under construction in the outskirts of Prague, and will be open in 2015. And I hope that I can welcome you to visit and to share with us some collaboration. Thank you for your attention.